Okay. First, I'd like to thank you all very much for inviting me to do this session with you. Wet labs are something that is becoming more of a conversation, and what the content is and how these things are handled. So I thought this would be a great discussion for us to have today, is creating a wet lab as we build confidence in our team, because we don't want people to be afraid to initiate Ecmo. So my name is Erin August. I am currently the coordinator liaison for the steering committee for ELSO. I have been a nurse for over 20 years, but in my time prior to being an ECMO coordinator, I was also a VAD coordinator. I've also been a flight nurse and a CVICU nurse. I have nothing to disclose. So for the introduction, so here are our points of order, our objectives for this talk this morning. So we're going to go through the importance of a wet lab, or some call simulation. It is very important to have that hands-on in a very controlled environment, that people are not afraid there to make mistakes. So therefore they learn before actually putting their hands and everything into action on a live patient. Elements of a wet lab and simulation, we're going to go over those things too, points to consider, points to make sure you include each and every time whenever you're designing your wet lab for your team. The also foundations and endorsed course, we're going to go over that as well, because these two items also are a great resource whenever you're starting or building on your wet lab and ECPR simulation platforms. And case scenarios from root cause analysis is another resource to pull information from in order to make your wet labs and simulations. I highly recommend that. Here in the United States, for the program I have, I'm currently at Cleveland Clinic, Florida. What we do as part of our quality assessment process improvement, otherwise known as QAPI, when we review any incident that may have happened, and we say what worked, what didn't work, how can we do it better. What we do is, if there's anything clinically that happens with the equipment or technique, we take it back and we work it into our simulations and into our wet labs to make it a final loop on our root cause analysis by doing continued learning from an incident. Power of simulation. As we know, over the years, simulation has grown more and more in the educational field, and we know that it has shown to prove effective. There is a lot of literature out there being published now that shows that simulation builds confidence, and it makes for better outcomes with our students going into practice, as well as our practitioners that are currently in the field. This goes across the board for all ECMO teams, whether you are an intensivist or a nurse practitioner or a nurse, RT, perfusion, ECMO specialist. Everyone benefits from simulation. Things that simulation and wet labs do for our teams is they increase confidence by making them not afraid. We know that we go back to just the general idea of education when we're learning in a clinical or a tactile manner. We know to see one, do one, teach one has always been an effective platform in the clinical world. So it definitely increases confidence. It also increases understanding. It's a controlled environment that allows us to be able to go through and stop and ask questions. So that way, when it happens live time and we really have to do this and in a timely fashion in order to save lives, we understand everything of why we're doing and how we do it. So also, if you look at and go online at elso.org, you can also look at the educational guideline. The educational guideline is also beneficial for us to understand what do we need to have in our elements of education? How often do we need to have these elements of education? And who do they feel benefits most from these elements of education on the ECMO team? And I don't know if many of you have seen this or you have ventured the ELSO website, but it is just a plethora of great resource. It also is beneficial in finding different conferences and educational activities to attend for you and your team. The also endorsed course is something that's growing greatly across the world. There is an endorsed course somewhere around everyone who's on this talk today. If you go onto the ELSO site, you can pull up and see which one's closest to you. These endorsed courses offer two things that feed back into your wet lab and also starting your educational platform for a full understanding of what ECMO is and what is needed of us to make it successful. There is the ELSO online portion of the didactics that you can take. It gives you all the lectures there. I believe, if I remember correctly, I think there's 53 modules that you can take that will give you your true didactic if you're just starting. It is very beneficial. It's a two-part course where once you're done with the didactic, then you can attend a hands-on course where we go through the 5 major scenarios that should be included in your wet labs, as these are the most common problems we as ECMO caregivers at the bedside will encounter. So two things in wet labs and also simulation. We look at skills and then we also look at situations. So where do we apply these skills to what type of situations? So, and when we're just doing the skills portion in the beginning of our wet labs, skills we should be constantly practicing are circuit building. Circuit building is everything from the time you take everything out of the packs to how do you put it together to how do I prime and do my wet to wet, right? So leading into the next one, priming is everything. So we want to make sure because we know all fluid has air in it. So we have to be careful and take our time. We can prime by the way that the manufacturers recommend, but also there's little tips and tricks that we as clinicians can share with each other to make it most effective to decrease the amount of air that may happen when we prime. Going slow, using your clamps and using gravity in the beginning is very beneficial to control and walk air out back up into the bag. Knobology. Knobology is also an important thing that we all need to learn and know and share. Depending on what type of console that you're using in your institution, it's good to know and share with others about how the console works. Remember, it takes many people to take care of one ECMO patient because you have the sickest patient in the hospital. So sometimes if there's something going on with the circuit, it's always good to have your bedside team know how to run the console as well. So in addition to having these elements of a wet lab skills for the ECMO specialist, it's also good to have competencies for what we would call ECMO knowledgeable, which is your bedside team. Everybody has a role and responsibility in an ECMO emergency and an ECMO initiation. So it's important to know and understand and define who is doing what in what situation. CRRT accessing. Some centers choose to run their hemodialysis off of the circuit. Some choose not to. Sometimes it's based on just beliefs. Sometimes it's based on the type of console that you use, whether or not you want to hook up or not. We know there's many different places that you can access. The safe zone per ELSO is post-pump pre-oxy. And we know in a cardio help, the way it's made, that there's only one way to access because a lot of people do not cut in a different place for that. So they just go pre-oxy, post-oxy. And transport. Transport's something else that sometimes gets left out when we're looking and developing wet labs. We need to be able to be ready for any type of scenario that may happen emergently. So adding transport into your wet lab scenarios or simulation scenarios that you have at your facility is important because we know the most common trip that you take with an ECMO patient is going to the CT scan. CT scan is very common. Second most common is the cath lab. So important things to know and practice, because although it may seem like, oh, we're just taking them here, we're just taking them there. Remember, you have the sickest patient in the hospital, and you have these large French-sized cannulas coming out of your patient, and you've got tubing, and you've got pigtails, and you've got stopcocks that could get turned. There's multiple things that can happen that sometimes we overlook. So it's better to be over prepared. The also essential simulations. So when we talked about skills, now let's talk about simulations. So these are actual things that can happen, excuse me, and are the most common things that happen in the Ecmo world with us. So, pardon me, losing my voice. We have air embolism, we have pump failure, we have gas failure, membrane lung failure, and drainage insufficiency. So these are the ones that if you were to become an endorsed course center from ELSO, these are the ones that they require that you teach. And they also will mentor you to make sure you have all the elements of how they like their simulations and wet labs to be taught. So air embolism, we know that can come from a multitude of things. One, it could be a low flow state in which we're too negative and we're pulling too hard and we cause cavitation. And then when the cavitation lets go, we know we can pull the air out of the fluid and cause a large air embolus and send it to the patient. We also know an air embolus can happen because we have to be able to remember and work it into our simulation of when we're placing lines or doing other procedures, using a rapid transfuser if it's, say, someone that needs rapid transfusion protocol. Anything that can cause the proteins to cause foam can also induce air into your patient if we are not careful. Pump failure. Pump failure can be a multitude of things. Whether you're using the cardio hop that's all in one, that would be a primary console failure, versus if you're using Rotoflow or Medtronic 560 or Sorin or any Centromag, any of those other consoles that we use out there that have a couple of different parts to them. In those cases where we can do things a la carte, you have a pump and then you have an oxygenator and then you have the console. On those pump failures, we could have an actual motor head failure versus is it a primary console failure? So it's all depending on your device. You want to think about the mechanics and how do you handle each one of those. Because we talk about a lot about hand cranking, but hand cranking is not for all consoles. So we have to be able to practice and know and time ourselves on how to change out equipment if it is a primary pump failure. So in addition to the wet labs and simulations, once you walk the team through these types of situations and get everybody comfortable, then it is time to time your team on how quickly can we change. And do you adapt these things into your program that maybe I don't want to just change the oxygenator when the oxygenator is bad, when my PaO2 post-oxy goes down. Maybe for me or my team, it's better to change the whole circuit, even when you know there's an inflammatory response, but risk versus benefit for the patient. Would I cut in a new circuit that takes 30 seconds versus do I cut in an oxygenator that may take me 1 to 2 minutes, depending on your situation? Gas failure. Gas failure is another one that needs to be practiced more often because we're finding that not all centers, I know when I go in and set centers up, some don't realize that your blender, which most people are using the Seacrest, although there are many types. There's a bird blender, there's the new digital blenders. There's a bunch of different blenders coming out on the market, but Seacrest has been around the longest. Remember, your blender needs to be have preventative maintenance at least every 2 years and tracked because they can fail. So things that we check and we track and we work into our simulations and wet labs with the gas failure is how do you troubleshoot that? Do you say, oh my goodness, okay, I walk in the room and my SpO2 on my patient's bad, which triggers me to start looking at things right away. And immediately I see that the ball inside the sweep is not floating. So immediately I know I've got gas failure when I even just visually look at that. So my first thing I would want to do is switch my green gas line from the back of the blender to my O2 tank that should be present at all times. If I do that and the patient stabilizes, then it could be that the first step I take is switching out the blender. If I go back to that and I'm still having issue, then the next thing I would suspect is that my gas at the wall is not good. So I'd have to go back to my tank and then work on either switching and maybe using a splitter, because we know we also have the ventilator, or do I need to talk to my charge nurse and move my patient to another room? These are things that we don't encounter often, but should be practiced more often so that we are ready for everything. Membrane lung failure, again, we just kind of work that into the gas failure. Again, it's how you and your center choose to, because we know even the circuits are different. So for the HLS set for cardio help, we know we have to do an exchange versus those that we have if we're using a Nautilus or a Euro set or another type of oxygenator, that we could change it out if we use a setup that's more a la carte, where I have a pump head, then I have an oxygenator. It's really up to center and physician preference, but also your team. Practicing these wet labs and simulations, again, builds your confidence. So is that something you choose to do that your team is more comfortable? Because it's really ideal if we can. We know we can't always, but if we can plan, if we're going to change out an oxygenator versus having to do it emergently, and see how well the patient can handle that type of situation. Drainage insufficiency. With drainage insufficiency, we are constantly looking to make sure that we're able to pull enough, and also we're making sure that our cannulas are in good placement. We really want to make sure that we're draining out enough to flow enough, but also in under drainage insufficiency, what they cover is a recirculation. So we know the phenomenon in VV Ecmo is recirculation. And, again, the way that some of the consoles are built, such as the cardio help, there is an indication that we teach in wet lab and in simulation that we can show, all of a sudden with your SVO2. Is it going higher all of a sudden? And you're like, okay, well, I'm looking and trying to see. And then when we do the chest x-ray, then you can see that the cannula in the right IJ and the cannula that's in the right femoral vein are have migrated maybe forward, that they're too close, that we need to reposition. There's different challenges to do with things like this. Again, making people aware, because we have all these different avenues to look at things and to identify things, to look further to see what happened with each one of these situations. So I have my skills. I have some scenarios. So what supplies do I need? So when I'm setting all these things up to run through them, it's based on your facility and how you have, one, the console you choose. Two, do you have a custom circuit that you have at your facility, or is it a standard? And then also, what are the things that you would want to keep close by? And because you want to make this as real to life as possible when you are teaching the wet labs and simulation. So these are a few of the items that you want to have available when you set up your simulations and wet labs for your team. Some people have a custom pack that has everything in it. Some of the people have peel packs that they use each thing, where they have a peel pack for each clamp. They have maybe a four clamps and a pair of heavy bandage scissors that they keep. Some people have it worked into a tray. A lot of the facilities that I have worked at over the years, we had a tray. We had a tray for initiation, and then we had a tray for change outs. So it was much more abbreviated. So, those types of things also help quickly, because when you're trying to move as fast as possible to fix a problem on a critically ill patient, you have to streamline. Streamlining is extremely helpful with that. And also, too, again, once you have the team comfortable with everything you're using, then you can start to work in time drills on how fast can you initiate, how fast can you address a problem, and then go back and then debrief on what worked, what didn't work, and then take it to your copy and say, okay, this is a process improvement that I'm going to redefine what my tray looks like. I'm going to redefine, no, we're not going to change out auctionators. We're just going to cut it a new circuit. There's different things that you can trial in your program for success. So I found some great videos online. I was trying to upload a lot of the ones from Gideon, but they would not upload. But some of our great colleagues out there, and if any of you are online that these are your videos, these ones I found were extremely helpful and they're very straight to the point. After these videos, I did upload for you. If you go to the Cardio Help website, there is a lot of how-to videos now. Abbott for CenturyMag has a lot of the same, and I've also found some videos out there even with Rotoflow and Medtronic 560. Those are still being used, and also now VitaFlow. VitaFlow is coming online, and I'm gathering some information like that. So anyone that would like videos of that, of those types of things, you know, if I can be a resource for you or help pull resources for you, my email address is eaugust@elso.org. So again, I am here for you to help set things up for you if you need it, have questions, concerns, or need resources for your wet labs and simulations. So the first video I have for you, and I just use CardioHelp because this is the one that is used most often, but all consoles count. But again, this is a unique one because it's all in one piece. It's not a la carte. We can just change an oxy, can change a pump head, can do this. We can cut in CRRT. We can do those things that happen with our a la carte circuits. This one's a little different because it's so compact. Mhm. One second. Okay. Now, I chose that one to share with you because it's a little bit of both adult and pediatric world when you're setting those up. So as you see, not everybody uses the manifold, but manifolds are used a lot in the pediatric world. Also, likes and differences are some people love the little plastic clamps that come with, some not so much. We have had trouble over the years with using the plastic ones because they tend to pop open. So we usually try to use the metal ones to follow behind. But there's likes and differences in that, and you can see the difference between adding a manifold versus if we didn't add a manifold, we wouldn't cut into the circuit. We wouldn't have added all those extra pieces. We do keep the prime line available just in case. So there are likes and differences, but this one I included just because it did show the manifold, which we know in our pediatric worlds, manifolds are used almost always. So try to get this, there we go. Now the next one I had here, oh, I'm sorry. Jeez. This one, oh gosh, this is like getting goofy on me, I'm sorry, is, so for this one, what we're looking at here is basically priming. So again, these great videos are all available to you, and I think that you'll like them because these ones were really, really easy to look through, understand, gather points, and great reference, excuse me, materials for you to build out your wet labs. So with this one, I'll kind of skip through it a little bit, but just to kind of give you an idea, some of our other colleagues built this one and it was really nice that I think you'll like as a reference. Right, and we saw those types of things before. There's the flow sensor again. So again, be careful with those clamps because they do pop open. Some places use saline, we use plasma light. And then you want to squeeze in so that way you're filling the bag all the way up. Remember, when you're doing these techniques in the wet lab, it's important to make sure people understand why you need to keep the bag level. Don't let it tip. because when it tips, we know that it can pull air. So although these steps seem very tedious and you're like, yeah, okay, I know this one, I know this one. Again, repetition is key to success with setting up for ECMO. And sometimes when we're in a hurry, these are little things that we don't practice over and over that make them muscle memory. We can forget or skip. And we want to do that on all of our devices, is make sure that the battery inside is good. Now, I'm going to stop this a minute and just to talk about that. So with the cardio hub, it's unique because we're zeroing each field prior to priming, right? And we know that with this particular device, that's important. So we get the most accurate numbers. Right now, another device that's on the market that you zero, but a little bit differently, is the Vital Flow. Any of you that have had any experience with the Vital Flow, we know when you do the setup on that one, you're going to put the clamp after the flow sensor, and then you go on the screen, and I'll send videos out of this to share on our WhatsApp site. When you clamp there, and then on the screen you'll hit and acknowledge to zero. Once that is done, then you can take the clamp off and you're ready. Most of our other consoles out there do not require zeroing. CentraMag is a very simple device unless you're using the pressures on it. Here in the United States, we don't use them that often because we use a lot of CentraMag either as a primary platform or for RVAD ECMO. And then we also have some of the older consoles that are still being utilized here as a Medtronic 560 and also the Rotoflow, which we don't have to do that here in the United States with the Rotoflow, which will be end of life next year in December. A lot of times the physicians and surgeons here tend to utilize more of a free mode type of thing. When you're working on your wet labs and things like that too, I stop here too, because a lot of times when we're working on all these other things, we forget about our heater cooler. Our heater cooler does not get the time and attention that it needs. And again, as something that may seem so simple to us, again, it's ECMO. We have to be prepared and ready for anything. Big things to remember with our heater coolers is to make sure we're checking the water levels. We're making sure that we're putting sterile water in there. Working along with the nurse at the bedside, if we see that our temperature is overriding, and to say, okay, does my patient have a temperature? Do they have a fever? Have you given Tylenol or something to address the fever? And then on my side, walking through the steps where I teach the staff, in the wet lab, what would be the first thing you do? Well, you pop the lid and dissipate the heat. Two, if that doesn't work, then I can go ahead and start dropping my temperature. If that doesn't work, then I can add ice. But remember, when you add ice most times is just coming from filtered water. It is not sterile. So therefore, you have to put it into a plastic bag, almost like a goldfish, and make a knot and hang it to the side, and then just let the ice down in the water in a plastic bag. They have found here in the United States before, when tracking back when we had issues with the mycobacterium in with the heater coolers, that it was from tap water that was put in. So therefore, we make sure that we put our ice into a plastic bag before placing it in there if we do need to go that far to bring down core temperature. So there's the connections that go on the bottom. Now, another important thing too, and I'll stop again when he puts the other side on. No, right there. When you're teaching your wet labs, here is another important thing to add as far as your heater cooler. Anytime you are putting your heater cooler on the bottom, you have to be careful of where you grab if you're having trouble pushing up on the bottom. For the cardio help, right here, I've had a couple instances with people where they were in a hurry to put them back. They forgot and grabbed over here, and it was just enough that they pushed on here that they decoupled the pump head. So I have worked that now into simulation. When we do a transport, mainly type of simulation, coming back when you're putting a heater cooler back on, you come back from CT scan, and you just don't say anything. You come over and you just boop, just push this just enough that it will decouple, and then you have people try to troubleshoot what is going on. So again, things to consider, because when taking these off and putting them back on, things can happen. So again, checking for leaks, making sure everything's good, running the air through, back up into the bag. Again, technique is everything. So even though it may seem tedious, again, repetition is key for success in ECMO. And you see how we keep our bag straight. Okay. And then we saw those before. Let's go forward. Air removal, I've included a video for you, for all of you that will have this, since this is being recorded, where it will walk you through how to remove air. So again, this is very helpful, and whenever you're trying to set up your wet labs and just kind of going through and getting your idea of how you want your scenario to go. Just show you real quick, and then I'll move on to the next, because I know we're for time. And you hear that right away. You can hear the air, you hear the decoupling almost. Now, if you notice too, and you remember from earlier when the gentleman said, "Oh, you trash these pigtails, use these pigtails." These are reasons why a lot of people are changing out and not using the tiny, almost pressure-like lines that come with the cardial help when they use the HLS set. Having the larger bore pigtails on allows us to be able to both give fluid, have better success with CRRT, and then also have, in this case, for fluid or for air removal. And you see, again, I added this with the manifold just because that way we're addressing both adult and pediatrics. Most places do not use the manifold for adults. Some do though. But in the peds world, manifolds are used almost always. And you start to become more familiar with that with your wet labs. And that's another thing that's helpful with a wet lab and simulation is that you can create the sounds that people need to be aware of when they're assessing, sitting ECMO, looking at things, because it's almost like you develop that ability, just like we do with alarms in a unit, right? We know which alarms do we hear that all of a sudden we kind of respond faster to, almost kind of like that Pavlovian response. So again, we can learn those same types of things as what we can touch, what we can see, what we can hear. The next one. Okay. Knobology. Knobology is another thing we were talking about, just going through and just becoming familiar with the console. So we work on our circuits, we work on how to prime, build, de-air, things like that with the circuits. It's also important too to know our consoles. And we may have more than one console in our arsenal that we have. So we may have, I have this many cardiohelps, I have this many centromags, I have this many rotoflows, I have this many vital flows. It's good to know each console and how to interchange them because you may have to end up going from one console type to cutting in a circuit on another one. So running these types of wet labs for your team is one, but also running them for who is going to be the person that helps you in a situation, in an emergency situation in the room. A lot of times in most places, it ends up being the bedside staff. So that's why it's encouraged that you train your ECMO knowledgeable bedside staff to at least be able to do the knobology of running a console if you need to be on the circuit. So again, it's all hands on deck when there's an ECMO emergency. Roles, responsibilities, and knowing the equipment is really a great key to success when you have and you're developing a larger ECMO program or growing your ECMO program. I won't go into this video too. So again, like this here. So I'll show you this one real quick. And again, you're changing from one type of console to another type of console because we know it takes a little bit to grow things and we don't always have a standard platform. Again, another good reason to practice removing this, trying to be quick and timely to get everything up to the field. Practicing how to take all these things off is extremely helpful, right? Because we know ECMO is very much attention to details and time. And once your team gets comfortable and goes through these steps by steps, this is the great time where you can get into timing your staff on how long does it take to cut in a new circuit? How long does it take cut in a new oxygenator? Decreasing the downtime of the patient. And here again, all about technique. We know this right here. This is something that I would have my team practice over and over again. I even gave them a piece of tubing with a 3/8 connector on the end and had them take it home along with two clamps. What I had them do is repetition over and over again, practicing the wet to wet, because the wet to wet, although it seems so simple, can actually be difficult, especially when you're moving quickly because you're trying to save someone. So just going through this and practicing over and over again, remembering air rises, remember how you keep your tubing straight to fill it with fluid and slowly tip, 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 and then put it together. These types of things that we practice over and over in wet labs, in simulation, but also at home. Again, I gave them homework. I would give them a piece of tubing with a 3/8 connector to do this, and then clamps so they could get used to and build the strength of their hands. So that way that they're able to clamp on tubing. Because all of us that have had to do these circuit changes, just like this one, we all know the viscosity of the fluid in the tubing also changes things. Clamping on saline or plasma light is different than clamping on blood. So, all these things are really good to help build everybody's skills for success. There we go. Okay, so here are the links. Just to give you screenshots. I was trying to get these videos to pull, but they wouldn't, unfortunately. But if you go to the Cardio Hub website and also Abbott, and there's several other sites, Medtronic is now adding these too. You will have these step by step, and it's great and kind of review too for the team. So say you've had a little bit of a lull and you haven't done any ECMO in a little bit, and now you have to. This is always good for just in time training. So, just in time refresh. If you haven't done something with a patient in a while, or you have a case coming up that you might be on ECMO standby, or things like that, that in addition to doing the hands on, you just want to run through it visually. These types of modules are extremely helpful. So, you see all the different ones they have here about how to use emergency mode when you push the red button if your screen cracks, how to use the emergency drive, so how to go into that hand crank, all those things here. They have all of these, how to detect arterial bubbles, how to prevent backflow, all those are there. So these things are extremely helpful, and I encourage them. Intra-hospital transport, again, doing the same thing. We talked about all these other scenarios. I do. I highly recommend. This is not done often enough, but it should be something that should be considered more often. And you really should perfect this technique through simulation and wet lab prior to doing out of house transports, right? We have to perfect in-house first. We have to have our house in order before we go outside. So the more practice you have, as I said before, the more you build the confidence of your team, the more your team is on board when it's time to go from in-house to out of house. Because why? They feel confident, they feel safe, and they've practiced enough that it becomes muscle memory. In the end, after doing all of these things that we discussed, debriefing scenarios are always a wonderful, great tool going forward, saying, yes, this works, this doesn't work. It creates, again, a platform and a place where you can safely ask questions. Um, and you should even do these after you have situations. So this debriefing applies across the board. So you start using it as best practices in wet labs, in simulations. And then when you take what you've learned and you've practiced over and over again in those wet labs and situations, then you apply it in the debriefings actual, after the actual scenario. So if I have a circuit change, well, let's talk about it. Let's debrief on it. What worked, what didn't work, what else might I need to add into my wet lab or situation next time based on my feedback and my debriefing on the actual situation that I've gone through, whether it's de-airing, cutting a new circuit, primary pump failure, all these things. Again, it only makes us better. It makes us faster and more efficient. In addition to different resources with the videos and things like that I gave you in this video for you to have as you formulate your wet labs and simulations, the books from ELSO are also a great resource to pull information from if you're making case scenarios. The CPR and resuscitative ECMO, the Red Book, which we all swear by, looking and pulling these types of things into when you're setting up. ECPR drills are a wet lab of their own. Why? Because this is really a great platform for you to have your entire ICU team. The Alfred in Australia, in Melbourne, Australia, I mean, they are fabulous at doing these types of things. I have included them as a resource on the end on my resource slide for you. They have a multitude of things online that are great if you'd like to look at them and use them for resources as you build out your wet labs and your scenarios. This is just kind of giving you an overlook of setting up a room for an ECPR, which is different than what we would set up for a wet lab or another type of situation, simulation. So again, it even looks at placement, right? Why? Because when we get to the point where we're talking about ACPR, we really have to consider and remember that F1 pit crew kind of thing when they change out the tires and everybody has a role and responsibility to be as quick as possible. And they know that their role and responsibility is just that one thing. It's the same as ACLS. When we do ACLS, everybody gets assigned a role. That's my role and responsibility, and I am not to do anything but that one thing. So again, that creates time and consistency to try to make it a successful code. So again, you see with this image here, it's that same thing. Everybody has their place and everybody has that letter where they know they need to be. And again, this is something else. Timed and repetition will make you quick, that the goal is to get onto Ecmo in less than 30 minutes. The last resource I'll give you is also the new blue book that came out. Again, most of you know that we have unfortunately recently lost our founder, Dr. Bartlett. So he has given so much to us and will always be remembered as the father of ECMO. So we were grateful that we were able to get the new edition of the Blue Book out, that we were also able to include him in this issue. Um, Again, he has given us just countless types of resource for us to carry forward his good works. And that's exactly what we're going to do. But looking at the ECMO Specialist Training Manual, there's a lot of great information in here to build scenarios from. There are tests in the back of each chapter. So that way, when you're doing your annual testing of your specialist for competency, there's a lot of great things you can use in here as you build your education. And here are the list of resources. Again, in addition to myself, whatever I can do for you, find for you, talk with you about, I am here for you to support you. And I wish you all and all of your programs continued and much success.
First of all, thank you so much, Aaron. We are lucky that you
Thank
are
you.
with us, and you gave us such a brief, complete training of the wet lab, for especially for the Ecmo, and especially big thanks to Kerala who introduced you for us. And see today for this session, almost more than 30 participants are still continues to listening to you, and your topic was very interesting. And I have few questions for you. I'm just introduce myself. My name is Ijaz. I'm from Qatar and the founder of the Book of Perfian. The page of this is belong to us, and we are very lucky, and we are looking forward to get more session from your side, as you are the key member in the also and playing a very good role to enhance ECMO knowledge among the globally. First question is not a big question, just for to sharing among our group. Mostly the people are from the Asian regions, from Pakistan, Bangladesh, Middle East, and all group are belong to this in this group. Uh, Question is, you just highlighted about the de-airing of the circuit, especially with the cardio help, and I just need to just need few words from your side at the time of the de-airings. Which part of the tube should be clamped in case of the air in the circuit? Number one. Number two, you just highlight about the hydrophobic port. How much time should we keep that the yellow cap, the hydrophobic port, should be open for a couple of minutes, and how much till time we can, and how much amount of like a syringes we need to suck out, and what is the like a setback if we connected the wrong pigtail of the syringe. We connected the syringe in the wrong pigtail, like instead of the pre-membrane we can connect it to the post-membrane. Would you like to just highlight few points on?
Sure, absolutely. No, so for the few that I'll answer quickly for you, in regarding to the pigtails, we always try to make sure when we set up, and this is another thing recommended, is that you keep at least one prime circuit at the ready at all times. Some places when you start to grow, you have a prime circuit at the ready, and then you have a dry circuit as backup that all you have to do is quickly prime it. With those things, we constantly keep a pre and post pigtail on there, so that way we have access at all times. We do prefer the larger bore pigtails, just as we're going to move into that, what you're asking about the de-airing process. It makes it much easier. The tiny pigtails that they have that are more like a pressure line on there, it makes it more difficult to try to push fluids in if you need to give fluids emergently, and also to de-air when you need to. Um, to access to de-air for that and also to push volume in, we always keep 30 and 60C syringes at the bedside. Those ones are the most helpful, because then you have enough space in there to pull and pull and pull until you get the air out, because we know depending on where it's trapped, and that's one of the things about the oxys. And remember when we were talking about in the wet lab of being able to look, listen, and hear, as you're going through and you're pulling the air out, you'll hear it slowly start to dissipate. So that kind of fizzy soda pop kind of sound will start to go away as you continue to pull and pull more air. You'll also be able to see that because you'll get more fluid into your syringe than air. So we'll pull up so much and then we turn off the stopcock and we'll hurry up and shoot that out just like they showed onto the floor. You reattach and you immediately start again. The yellow cap, you can leave that off for multiple minutes to help you dissipate the air out of there as well. It's a one-way valve. So again, air is going to go out. You're not going to suck anything in. So you do have as much time as you need in order to correct the problem on that one. So tell, which other questions did I miss? I'm sorry, I was trying to group them.
No, no, you answer all the good, and just I need to highlight one thing more. Just for the
Yes.
interventions, what are the interventions required for the ECMO patients for the parameters? We need some interventions. So some limitations where
Yes.
the machine activate itself the time there's like air in the circuit and your access is going higher. So what are the parameters where we need to set the intervention modes?
So the intervention modes, the most common one that is used, and again, a lot of times it's more surgeon driven. Which ones do we keep on? We always ask our surgeons in the beginning of what they would like set, what they don't want, if they want it left at the factory settings, the recommendations. The biggest one that we utilize here is the bubble detector. So the bubble detector is on all of ours except for whatever reason, I don't know why, but the surgeons tend to like to stay in free mode when it comes to a rotoflow. But because we know the rotoflow does have a bubble detector on it as well, but they tend not to like to use it on there for some reason. I can never give anybody to give me a straight answer. They just say no, just stay
I
in free mode. Okay.
sorry, and I can just want to give some input regarding this.
Yeah.
We always recommend in Qatar, we always recommended not to put intervention for the bubble, especially for the arterial side, because in case of we'll fix the intervention on the arterial. So if someone who's the bedside is not capable to detect that this intervention mode will going to stop your machines. But if there is a micro, like you're taking a sample from the post membrane, and the
Mm-hmm.
micro nano
Yes.
micro bubble will sense and machine will going to stop till you
Yes.
deactivate the intervention mode, and sometimes your staff is not able to remove the intervention mode, and then maybe you're going to lose the patient. So this is the reason we don't want to fix intervention mode, especially for the arterial bubble side. Yes, venous bubble is okay. Intervention mode usually we fix for the excess pressures and pre and post pressures, not more than that, because excess is the major point where we are sucking blood from the excess side, and we don't want to take it above more than the 100 millimeter mercury. If it is going above than minus 100 millimeter mercury, the excess pressures mean the shear rate is increased and the excess line, and you're going to traumatize the blood cells. And if you are going to ignore the excess pressures, although your machine is alarming that your excess is higher,
Mhm.
then there is a chance of the cavitations. As the when the cavitation is going to happen, there is a chance of the airlock, and you can give a huge amount of air in the patient circuit. This is the reason we always keeping intervention mode for the access and pre and post. And access pressure, especially in the cardio health, we always go with the RPM, with the revolution per minute. If you talk about the cardiac surgery, we are going with the LPM, with the liter per minute. So demand for, especially for the ECMO patient, if you're using like the kinetic force, the centrifugal pumps. So we always giving the command of the RPM, revolution per minute. But if you talk about the cardiac surgery, we go with the liter per minute. So we want like a liter, so adjustment with the liter. But with the ECMO patients, we always keeping with the RPMs, because we adjust the flow and pressure with the RPM, not with the liter per minute. So usually we recommend it, especially for the VV ECMO, and for the V and the EV. We requested and humble request to our bedside nurses, even that we will not going to fix the intervention mode, especially for the arterial. For the venous side, yes, we used to
Mhm.
do.
Mhm. No, that's great, and I totally echo everything you said because it's like in with us too, with the surgeons I work with. See, they're definitely flow fixated, right? I mean,
Yeah,
that's all
yeah,
they
yeah.
want to do. They just want to be able to flow, right? That's all.
Mhm.
But to
Mhm.
your point, absolutely, and that's why we make sure that the ECMO specialists and we kind of have it timed in PRN as far as gases go, because absolutely
Mhm.
right. With the viscosity change, if you're flushing up you draw a gas and you have an intervention on, especially on the cardio help, then we're going to have a problem where it stops. The nice
Mhm.
thing about the vital flow now is
Mhm.
it has equally that sensitivity where it will do that. It will alarm if there's a viscosity change because it thinks it's a bubble, even if it's not. But the only thing
Mhm.
with the vital flow is, unlike the cardio hub, the vital flow will not stop. It will continue to flow. But agreed with all your points. Thank you for
Yeah, yeah,
you
yeah,
were faster
yeah.
at
No, no.
summarizing it than
La
me,
la la,
so I appreciate
your
that.
presentations really, really, we are looking to see this type of one presentation, and you covered all the things which we required for, especially for the simulations, because we are doing simulation here in Qatar, and this month, even 16th, we have a comprehensive course for international our friends from around the regions, and we are covering all the things. We have like Dr. Nick Barlett and all these are the member with us here in Qatar. And thank you so much for any my friends have any
Thank
questions,
you.
please. Forum is open.
Yeah. And if you think about things later, again, my email is
Mm.
eaugust@elso.org. Again, I make myself available to you all times. So please feel free to email me, and I am happy to help you and answer any questions that you have.
Uh,
And
uh,
Aaron one, yeah, please, yeah. Yeah,
Thank you,
Naveen.
Aaron. Good evening. Thank you, Aaron. This is a wonderful
Thank you.
presentation. Myself is the Muhammad Naveed, Cath Lab Technologies from the Hamad Medical Corporation, Qatar. Actually, this presentation
Nice to
has
meet
been
you.
incredible, valuable, since the full progression from the foundational of the wet lab skills throughout the LSO protocols, standard emergency simulation, and right up to the integration of the ECPR drill.
Yes.
Uh,
I mean,
as a
it's
cath lab,
very
as
helpful.
as a
I'm
cath
so
lab
sorry.
team member, I see these
Mhm.
direct applications. I just want to say about your presentations, the wet lab are the not the just the training. They are the team building, skill resharpening, and the life saving rehearsal. I just have these small questions about the eCPR.
Mhm.
In in the slide you just mentioned, the eCPR is the one of the most demanding procedure in the this Ecmo procedures and the emergencies. Why the wet
Yes.
lab training is so critical for the eCPR?
So with that, because it goes beyond just the specialist. So usually when we
Hmm.
have the ECPRs happen, again, it's like ACLS, right? So we run
Hmm.
and we constantly practice for ACLS. And then when you have ECPR, now you have the ECMO team that comes in and layers on top of the ACLS. So now you have two teams working together. So say for instance, in the emergency room, right? We have a patient come in that ends up having a code and they meet criteria that they would qualify as a candidate for eCPR. You activate your internal system that triggers your ECMO team to come to wherever this patient is. Once they do a quick evaluation that's done by usually an intensivist and a surgeon, then they'll go ahead and say, yes, we're going to go ahead and go on. So again, it's knowing those roles, responsibilities that you can quickly follow that same type of platform as ACLS. And through practice, everybody understands, just like in ACLS code where you have the recorder, you have the person who's running the code, you have someone who's pushing the meds, doing those types of things, manning the airway. If those things were just layering onto that. So now I have my cannulator. Now I have my ECMO specialists that are going to help prep and get the circuit ready. Just making sure then your team has a chance to understand too, where do they fit in? Because we know we get in awkward spaces as well when we're doing eCPR because we're not in the unit, we're not in the OR, we're not in the cath lab. We could be anywhere in the hospital. So practicing and understanding that way, we know how the team is comprised of, and then you also know your role. Then you also know where can I fit into with a space that is not of my own. It really makes it helpful. And again, it builds confidence because when people go into a code, just like you have people that sign up and practice to be part of a code team, your code team is now expanded to include your ECMO team and they understand their role and responsibility in a code. Does that make sense?
Yes. Yes. Sometime of this type of the issues is also facing during the just transferring the patient from the cath lab team to the ECMO team, because at that time is the
Mhm.
very critical situation. Everybody is just in the panic conditions.
Yeah, yeah, and well, and that's the other thing to practice even along with you in your space. If you're already in the middle of doing a cath lab procedure, you're very essential in helping with timeliness and getting on ECMO because with you being in the cath lab, you and your team, and then maybe you already have access because you were doing a cath lab procedure, which makes it easy because then the surgeon will jump in with the interventional cardiologist and together they can cannulate the patient together along with other members of the ECMO team, and again makes it timely. So it's working along with all the physicians in the different places, so everybody understands, when do I call, who do I call, how does the system work, who are the extra people that are going to come and layer on top of your code team that's already doing ACLS. So because we all know codes can be chaos, right? We know that. And a lot of times that somebody has to be point and own the room. They have to run the room and control the room. And so whenever the ECMO team comes in, a lot of times then they can work along with the physician who's running the code to control the room, set the tone, and go into that where they become this efficient machine in order to be timely to save a patient.
Yes. Yes. Thank you, Aaron.
Thank you. Thank you.
Aaron, do you have feel the time of in ECPR, especially when Naveed can tell, especially when the time of the ECPR activated, to cannulate arterial will be the big challenging because the patient's already going to be collapse, and to identifying the arterial and the venous side will be a difficult, especially time of the ECPR. Have you
Usually what we'll
experienced?
do, yeah, no, we try to keep a sonosite available at all times. So when we
Okay.
have our setup, so we can visualize to your point, because it's hard to go blind. Absolutely. In those types of situations when you have someone coding and you're trying to find a vessel, especially arterial to cannulate, we keep a sonosite along with our ECMO carts and a prime circuit. So that way we have those three things that we can go anywhere we need to go and quickly try to find the setup and quickly find the vessel to cannulate and try to do our best not to have a retroperitoneal bleed.
I agree, David. We need also at least ultrasonic things available, fluoroscopy, so we can identify. And the size of the arterial cannula, return cannula, should be the smaller, because mostly the newly centers, the our colleagues are newly, like in some of the center they started newly, and the time of the ECPR. By mistake, and they will open the like a perfusionist or whoever they are, like ECMO special nurses, so they can open the big size cannula. So in a ECPR, we always recommended to keep a return cannula should be the smaller size, like with a small French size, so you can easily cannulate.
Yes, and that's some of the centers I've worked in, what we've done is when we developed our ECPR cart, basically what we did is we utilized a BSA of 2. So we say if you are, and we just streamlined that this is what you have, because all we're going to look to do when doing ECPR is we're looking to get you on support to stabilize you and then move you to a controlled environment where we can reassess whether it be the cath lab or the OR. So if we need to do any kind of repair to a vessel, or if we need to add the distal limb, or if we need to reconfigure, we can do any of that in a controlled environment. So we utilized the Levanova tandem cannulas that are tapered cannulas, because we know that the patients are already so clamped down, because with ACLS, we've already given all these meds to maintain blood pressure. So we're clamped down. So we did something that would minimize the damage to the vessels when we're trying to get in. So we did a BSA of 2. So below 2, we did a 22 French drain and a 15 French return. And then above 2, we did a 17 French arterial, and then we did a 23-25 tapered drain. And we kept that as kind of our standard when we did things. So to kind of standardize, based on your cannula preference, to just make sure you get enough flow to stabilize the patient, then at least then you can get to another area where you can reassess the patient, gather more information, whether it be stabilize and go to CT, stabilize, go to cath lab, stabilize, go to OR. At least it gives you the ability to have control, to protect the vital organs in the brain, to find out further what's going on.
Thank you. Any
Yes,
questions? Otherwise, we will.
no,
Any
no,
question,
actually,
please?
actually, I just want to add the small things. Actually,
Uh-huh.
being a cath lab technologist, actually, in the many cases, I saw this a main problem to get the access on the time from the Ecmo team. So I just want to be
Mhm.
share. Actually, our most of the cardiologists, if see the patient is going to serious or in the cardiogenic shock or the suspected, they already get the access for the ECMO team. So meanwhile, once we just need it, we just call the ECMO team, and I saw this only, I think, within 3 minutes, as I just measure, within 3 minutes we just done the via ECMO on time. So I just want to ask, is it the Aaron, is there any protocol for the cardiologist and the ECMO team for this kind of this scenario?
So what we do and with those types of things, there's just basically it's just center specific. It's how you structure your team and what roles and responsibilities to be. If you would like
Mm.
to email me, I'm happy to look into that and also reach out to colleagues to see if anybody does have a particular protocol that would address, what you're facing at your center to have further discussions. We're very good about sharing things because team structure, again, that's why ELSO and ECMO are still more guidelines at this point, when we do have things that are policies and procedures and protocols. But again, the team structure and roles and responsibilities still vary from place to place, because
Uh,
I've been in centers where it's been, just the surgeon does everything, or we
mm,
have cardiology maybe help, or we do intensivists that maybe help.
yeah.
So there's still a wide variation.
So sorry, Erin and Naved, you know
Mhm.
what we did here in our protocols? We trained our ED doctors. So the time of the ECPR, so they just keep ready the lines, and we just came and just go through with the ECMO cannulation within 1 or 2, 3 minutes, and we save the
Wonderful.
patient because so once we in our training program we always keeping the ED doctors. So we trained them in simulations in our simulation center. So we gave them practice to how to cannulate the patient. So the time the patient in a critical, they always initiate 2 lines arterial in the fem, and that in case of the patient go deteriorate, so they give activation of the ECMO. So we save the time the patient's already having the guide wires inside. So once we reach, we just cannulate it and go through. And now we go in a second step. We already trained them to can how to cannulate. So mostly here in
That's
Qatar,
fabulous.
we have two
Yes.
teams. One in cardiac surgeons, like we are the perfusionists, and we train our nurses in MICU. So we intensivist group are doing the ECMO, like VV ECMO, and mostly the patients for the V and the ECPRs that was done by our surgery team, and we divided the role. So like in a whole in corporations, our all centers, our ED doctors mostly on a duty. We trained in a shift doctors who's available in any hospitals, like in Hamad, we in Qatar we have different hospitals which is coming under the government public sectors, the Hamad Medical Corporations. So we gave them training like years. We have two comprehensive courses we are running. So our ED doctors are ready to cannulate. So once we reach, we just connect it and go on a bypass on ECMO.
Oh, okay. Actually just want to ask, is it the hospital protocol or this is the international standardization for
Lala,
this?
this is our hospital. This is our hospital protocols, and it is going to according to the our also the guidelines. So Ibrahim Fauzi, we are running here the
Mhm.
SWAC also. So we are the member of the also, and we are the key member of the SWAC also. So our guidelines is going. We are getting from the also, and the protocol we set here is like our hospital protocols.
I
Okay,
love
okay.
that.
Thank you, Ijaz. Actually, Aaron is also mentioned that this is just some verbal or mutual agreement between the cardiologists and the surgeons for doing this kind of the things.
You will find in our guidelines. If you go to
Uh,
hit the Hamad Medical Corporation's ECMO guideline, you
mm,
will find all this there.
okay, okay, okay. Thank
That's
you.
wonderful. I'm gonna have to look too. Thank you for that. No, I'm
Thank
excited. I'll have to
you.
come to
Thank
SWAC
you.
also one of these times.
Yeah. So the first WAC also was in Qatar, and then we the last now the third this WAC also is coming in India in Chennai now in a fab. So last was in
Very
Kuwait,
nice.
and we love to see you, Aaron, here in Qatar. Please join us.
Thank you. Yes, I would
Thank
love
you.
to. Thank you so
That's
much
sure,
for
sure, sure.
everything.
Thank you, members, for attending a long, lengthy, and very interesting and very informative session. And please give my regard to Carla. Carla is the one who just mention your name for to have this session, because she said you are the very intelligent and very active in ECMO, and she should be in this group to present something. Thank you so much,
Well,
Aaron,
I
once
appreciate it.
again. Thank you so
Absolutely. Thank
much.
you.
Bye
Thank you,
you.
bye.
Bye
Take
bye.
everyone.
care. Take care. Bye bye bye. Shinzan.